Good afternoon, my name is Sue Bozman and I'm an advanced nurse practitioner for the St Andrew's Burn Centre in the UK, and I've been asked to do a presentation today on best practice in paediatric burn wound management. The St Andrew's Centre is a super-regional burn centre. We cover a population of almost 10 million patients, and the area in blue on the map is the area that we cover. So most of our patients have to travel an average of between 1 and 2 hours to come to us as a burn centre. We have our own dedicated burns theatre which can run 24 hours a day. We also have an intensive care area with 6 beds. 4 of those are intensive care and 2 high dependency for adults and children. We have an adult rehabilitation ward with 8 beds, a children's ward with 8 beds, and a burns outpatients and outreach dressings clinic. These areas are all run by specialist trained burns nurses, children's trained burns nurses. We also have a safeguarding lead nurse specifically for burns, and we also have a burns case manager. These are our monthly figures for children and adults that come to our burn service. The area in red is children and white is adults, and as you can see we have approximately 100 patients of each every month that come through the burn service. They're not necessarily all admitted, but they all come to us with significant burn injuries. The most common type of burn injury in the UK is the hot drink scalds. These are primarily in children under the age of 2 years. There's around 30 per day across the UK, and we see approximately 4 of these children in our burn service every day. A little bit about my professional journey. I originally started as a nursery nurse. I then did our 3-year degree course to be a registered general nurse, followed by a 2-year degree to become a sick children's nurse, and then later on in my career I did a 3 years master programme in advanced nursing practice so that I could be in my current role. I'm also a non-medical prescriber, which means I can prescribe medications. I am a mental health first aider, which means I can provide emotional and psychological support to staff. And I'm also a safeguarding liaison, which means that I can keep children and adults safe from a safeguarding perspective. I've been working in the burn service for more than 25 years. My role in terms of burn wound care means that I can accept and assess new burn referrals as they come through the service. I can make a plan of care, assess the wounds, prescribe medications such as antibiotics and painkillers, and I have an advanced knowledge in dressings and wound care. My focus primarily is on patient safety and making sure the patient's experience is a good one. I work very holistically across the burn service, so it's a bit of a hybrid role. I'm not a doctor as such, but I do work at the level of a junior doctor, but I can bring the medical model mixed with the nursing family-centered holistic care approach. In the Burn Centre, we strongly believe that wound healing is a multidisciplinary approach. We have a very big burns MDT, and it's really important that everybody is involved in the care of the patient and helping their wounds to heal. As such, we have a group from the MDT who get together. There's usually a surgeon, an advanced nurse, a therapist, usually somebody from our pharmacy department, and we sit down together and we produce documents such as this one, which is on hypertrophic granulation, and we look at different aspects of wound healing and what we can do in terms of best practice. We set them out clearly in a policy such as this one to share with our team to make sure that we're being holistic in our approach to wound healing. As you can see from this particular policy, we're looking at first line and second line hypertrophic granulation at the different stages of wound healing, and we really do consider it holistically and look at all the different aspects. We also produce short videos such as these ones here, which are used with QR codes that patients can scan on their mobile phones. We've recently produced a video on itch because we know that wound itch is a really big problem, particularly in our children. We're also looking at the transition period. When a child turns 16, typically in the UK, they move into the adult services, and this can be quite a big move for them, quite a big transition. So we've done a video on helping that. And we've also here got a video on if a child is going to theatre, just a short video they can watch with their parents to prepare them all for the process. It's very, very important that we communicate well with our families, and these type of videos that we produce as an MDT help to make that process easier. I'm sure we're all aware of the different stages of wound healing that are widely published. But really it's just to remind ourselves that actually this is a dynamic process. The phases do overlap, but a wound must go through each of the phases to be able to heal. And often with burn wounds, we seem to get stuck in the inflammatory phase. Inflammation can be very helpful for a wound, but prolonged inflammation can be detrimental, and it can be a real challenge in wound healing. You may also be aware of Jackson's traditional method of burn wound injury that looks at different zones. They describe 3 zones of a burn wound injury, and really it's just to recognise that actually burns tend to be different depths in different areas of the wound, and this can give us an additional challenge when we're thinking about wound healing and what we need to do to get a wound to heal up. It's really important in wound healing that we're aware of the factors that affect wound healing, and one of the most important ones in a burn injury is the size, depth and mechanism of the injury. That really does help us to decide how we think this wound is going to heal and whether it will need surgical management or whether we can manage with dressings. Wound infection is a huge problem. And biofilms, I think we really struggle with biofilms in burn wound injuries. Exudate is a big problem. Burn wounds tend to be quite heavily exudating, and oxygenation and blood flow are also really important points to consider when we're trying to decide whether a wound will be able to heal. We do use surgical management early in burns if necessary in terms of early debridement and skin grafting, but not every burn wound will need surgical management. Very important that we consider the other aspects of factors that affect burn wound healing, particularly in children, things like pain and stress, whether they've got good nutrition. Sleep really significantly affects how a wound can heal. Very much with the child, it's around their age and stage of development and how concordant or compliant they can be with their wound care. And so our choice of dressing is really important, and it will very much depend on the wound type that we're looking at, and it's important that we look holistically at all the other factors that may affect wound healing when we're thinking about what type of dressing to use. As we know, burn wound infection is a significant issue in wound management of burns. They are very high risk, and it's sometimes quite difficult for somebody that's not experienced in wound care to identify what is actual infection of the burn wound and what is actually just the normal inflammatory process. We do consider using antimicrobial dressings and creams. They are really important in helping to prevent infection and to treat infection. And the natural ones like your honey or your FLAMINAL dressings can be really useful, particularly in children. In the UK, we only use antibiotics for children with burn injuries if they are systemically or clinically unwell and their burn looks infected. We don't use them prophylactically to prevent burn injury because we're very cautious about antibiotic stewardship and the problems with antibiotic resistance. We do routinely swab our wounds on the first appointment and at any appointment after that, or at any stage in the wound healing after that if there's signs of infection. But we don't routinely use antibiotics. Wound cleaning is another area of wound healing that's really important. There isn't really any research to suggest that sterile water is better to be used in burn care, and we tend to just use warm tap water with a little bit of baby sensitive soap in the water to help with cleaning. And in children particularly, we just use a soft cloth and gently wipe over the wound to remove the exudate. In adults, sometimes we're more likely to use scissors and forceps, but in children, because of the additional risks, we just tend to use a soft cloth, a nice big bowl of warm soapy water, and where we can, we get the child to help us or the parent to help us with wound cleaning so that it's not so distressing for them. Debridement of blisters can be a contentious area. However, in our burn service, we always recommend that blisters are gently removed. We see them mostly in our superficial and partial thickness burns, but it's really important that we remove any blister that is bigger than the patient's little fingernail, just as an example. We never puncture a blister and leave it intact. And again, we use a bowl of warm tap water just to gently clean away all of that blistered, devitalized tissue. We have a clear rationale for debriding blisters away. It provides us with a nice clean wound bed, and it aids us in our assessment of how deep and how big the wound is. It does reduce the risk of infection because you're removing all that devitalized tissue. It can be more comfortable for the patient in the long run, although the actual debridement can be uncomfortable. Tends to give them a better functional and aesthetic outcome, and definitely helps to stop the restriction that tense blisters can have if they're over a joint. These pictures really do demonstrate the importance of removing the blisters and providing a clean wound bed. It would be very difficult to assess how big and how deep the burn is while the blisters are in situ. So it's very important that we remove them. We also can't start to actively treat the wound bed if it's covered with devitalized tissue. Our Burns Network has provided clear protocols and guidance on de-roofing blisters and the management of burn blisters, which we share with all of our referring hospitals just to help them be really clear on the management of blisters and the importance of debridement of burn wound injuries. Exudate control, we know, can be a huge problem. There is a lot of exudate that comes from particularly a new burn wound that's partial thickness. It can be a real balancing act between not wanting to dry the wound out too much, because we know that a wound needs a warm, moist environment to heal, but we don't want to dry out the wound and stop that healing process. It can be really tricky, and at different stages of the wound healing, you may need to think about different ways of managing the exudate. With a dressing that we use frequently, such as FLAMINAL, it comes in two different types. So you've got your FLAMINAL Forte, which is for your moderate to heavy exudating wounds, and then you've got your FLAMINAL Hydro, which is for your low exudating wounds, because it actually hydrates the wound bed. But it is very important that we choose the right dressing for the right level of exudate at different points in the healing process. One of our biggest challenges in wound management is itch, particularly in children. It can be really challenging. You can have acute itch, which occurs at the time of the burn injury and ongoing whilst the burn's healing, and then chronic itch when the burn is healed, and it can continue to itch for a long time afterwards. It's really, really challenging for us, because what we find with the children is they'll have a wound that's almost healed, and then they scratch and they break the wound down, and you can get into this itch cycle, which is very frustrating, where you get a constantly breaking down wound because of the itching. We've tried to work really hard on this as a team, and we always recommend practical things to the parents, like encouraging the children to tap rather than rub, because we know that rubbing increases the friction and therefore the heat, making sure they have short nails, making sure they're wearing cool cotton clothing in a cool environment, those kind of things. Antihistamine medication can be quite helpful in some children, and managing the wound bed is really important, and anticipating itch and when it's going to occur. So trying to make sure you use the right type of dressing depending on the wound exudate will make a big difference to itch as well. But we do find it's a real challenge, and I would be really interested to find how other people manage burn itch. These are our MDT burn itch guidelines. As you can see, we separate them into early burn itching or acute burn itching, and then late burn itching, which is our chronic burn itch after the wound is healed. And we really do try and look at this holistically in terms of the wound bed, in terms of the topical agents that we can use, the prescribed agents that we can use, other interactions that might help. But it is still a very common problem, and it's important that patients and parents anticipate and know that this may happen and that it's actually very normal, but it is a really challenging part of the wound healing process. Of course, we know that burn wounds can be very painful, and again, it's another area of wound healing that can be a real challenge to us, separated again into acute or chronic pain depending on where the patient is in their wound healing journey. And it's very much in children linked to their age and stage of development as to how they demonstrate that they have pain, and whether it is pain or whether it's anxiety. We know that some children will cry just because they're being approached by a stranger or a healthcare professional, and it can be quite difficult to assess levels of pain in children. Parents are very helpful in this instant because they can help us with that. Previous experience of pain or hospitalization can complicate things, and it really will depend on the size and depth of the burn as to how much pain children experienced. Dressing type is really, really important. We know that some dressings can be more antagonistic than others and can make the pain worse rather than better, but we also know that some dressings can be very soothing. So things like creams, like FLAMINAL creams, can be really soothing on a wound and can really help with healing, whereas we know that some of the silver dressings, for instance, some children can have a bit of a reaction to them and it can be a bit antagonistic on their skin and increase their pain levels. So they're all really important things to consider. We use the Wong and Baker smiley faces that you'll probably be familiar with to help us with the smaller children to be able to identify their level of pain. We have lots of protocols within the burn service to help us to manage different parts of wound healing, and this is our protocol for managing pain and itch, which we have, which very clearly sets out for us the different types of analgesia we should be considering alongside holistic management of pain and itch in children. We also have a policy on managing painful dressing changes, which looks at things again around what are the other options that we can use instead of analgesia in helping a child to manage a painful dressing change. And these involve things like distraction techniques, etc., etc. Creating a positive patient experience is so important. We are very lucky that we have a lovely environment for our children's burns ward, which is very child friendly and family friendly. We encourage the parents to be there with the child at every stage of their wound care, including their dressing changes should they choose to be. We have specialist trained staff, including play specialists, who help to provide support and distraction to the families. And we run a 24-hour ward and outpatient support. So if it's the middle of the night and a parent's concerned about their child and they're at home with them, they can just ring the ward anytime, day or night, and have a conversation with the staff, and we can provide them with reassurance or advice and support. And we do run a very family-centered, family-focused approach to wound healing, because it really is a team effort to get these burns healed, and it's very important that we have the family on board. So working in partnership with the family, sometimes we try to get some of the wound care done at home, and there are some clear benefits to that in terms of the child being in a more friendly, familiar environment. The family can fit the timing of the dressing around their family life, so they can do it after the child's, for instance, had a sleep, so that they're not so grumpy, or at bedtime, or whatever fits them better. Definitely reduces their travel time and costs of coming all the way to the hospital to see us, less impact on their family routine, means that children are not missing school, and the parents can be more actively involved in the child's care, which for some families is really, really important. And so we do encourage our parents to change dressings at home if we think they can manage, but we do have a support system in place where if they're doing the dressing at home and they become concerned, they can give us a ring directly through to the children's ward, send us some photographs or do a quick video call with us, and we can have a chat with them and reassure them that everything's going okay. Of course, wound care at home isn't for everybody. For some children, it's really traumatic and the parents don't want to have that trauma in their own home because it's important that home is a safe place for the child. They may be unable to tolerate the dressings at home, which would make it very challenging for the family, and they may not be able to give them the adequate analgesia or pain relief at home for them to be able to cope. Parents really struggle, we know, with anxiety and trauma after a burn injury, and they may be experiencing guilt, and it may be very difficult for them to feel like they can give their child more pain and distress by changing their dressing at home. They may not be able to do the wound care successfully, they may have poor technique, and we do know that in some environments the home environment may not be as clean as it could be, and therefore there could be a risk of infection. So dressings at home isn't for everybody, but we do encourage it where we can. I think it's worth us recognising that the right dressing for the wound is not necessarily the right dressing for the patient, and this can be a real challenge for us, I think, because sometimes the perfect dressing that we want to use is not the right dressing for the patient for many reasons. Some of those reasons may be they just don't tolerate it, they don't like the dressing particularly, the exudate isn't being well managed and so it's very wet or smelly and they get worried, and it really will depend on when you're going to change the dressing next as to how long the dressing can be left on for, as which dressing you use. So we do have to be adaptable, and sometimes what we feel is the ideal dressing for the wound is not the ideal dressing for the patient. So honey dressings are one of the dressings that we do sometimes use in children. It's been around for a very long time, more than 4,000 years. It's a nice natural dressing with a low pH, sugar solution with lots of vitamins and minerals and enzymes in it. Really good for your slightly deeper burns that are necrotic or your infected wounds, because it's very good at autolytic debridement of your devitalized tissues. It does osmotically draw the fluid from surrounding tissues, and so it can feel a little uncomfortable, particularly in children. They can find it a little bit stingy and a little bit drawing, which they sometimes don't tolerate, but it does reduce wound edema and it is a good anti-inflammatory. You do have to, rarely, but you do have to be careful about bee venom sensitivities. So we do use this in some of our children with the slightly deeper burns where they've got a small area that we don't necessarily want to put them through a skin graft surgeries, but they need something that's going to be quite active on the wound. We use a lot of FLAMINAL in our wound care, supports natural healing. It's really versatile because it's a cream, so it's very easy to apply and it conforms to difficult shapes. In children, typically hands and feet are involved, and it does conform really nicely. You can use it on a wet or a dry wound as long as you're cautious about which type you use, whether you use the Hydro or the Forte version. And the really good thing about FLAMINAL is it can be used in any age group, so we can use it on our very smallest, youngest children. It's a really nice debriding gel, but it's also a nice kind alginate, which doesn't tend to be stingy or uncomfortable, and it's quite easy for the parents to use. We also find that it absorbs quite nicely into the wound, so you don't end up with that slough across the wound that you get, or film that you get across the wound with some of the other dressings that needs to be cleaned off quite vigorously. We don't tend to find that in FLAMINAL, which can make it much kinder for children who don't tolerate wound care very well. It's great because it's got low cytotoxic effect on epithelial cells, and we do find we get some very good results from it. We do use silver dressings. They have been around for quite a long time, and they were the standard topical agent in wound cares from the 1960s. You do have to be a little bit careful because some people have silver sensitivity and they can find it quite uncomfortable as a dressing, as a wound. Renal toxicity is also a risk in young children, so you have to be careful on using it in very small children. And the amount of concentration of silver that you get will vary depending on the type of dressing that that you use. Some of them are long-acting dressings which slowly release the silver into the wound, and others like Flamazine have a short half-life and need to be changed quite frequently. They do have their place and we do use them, but in children we tend to try and go for the more less toxic options like the FLAMINAL dressings. Silicone dressings are really helpful, particularly for children. Something like a Mepilex border, self-adhesive, which parents can apply and remove very easily and without trauma, are very useful, particularly as a secondary dressing over the top of perhaps a cream that you're using, like a FLAMINAL cream. They are a nice, easy dressing to use, but on their own they don't have any active properties. They're more of a protective dressing. But as a secondary dressing, we do find them very useful and we do use them quite a lot. The safe technology means that they do come off of the wound really easily without causing trauma, which is very important. We find facial burns a real challenge. We find it really difficult. We see a lot of children with facial burns where they've pulled hot drinks from above over their face, and they do need to be cleaned generally 2 or 3 times a day, which can be really traumatic for the child. We always use soft yellow paraffin like a Vaseline, but it's not active. It purely just keeps the wound moist. But more recently we've been using Flamigel, which is a hydroactive colloid gel, which is really kind to the skin, and we've seen some really good results with it. It's quite easy to apply and it does absorb really well, so again you don't get that slough that you get with yellow paraffin where you get an exudate that sits on the wound. But facial burns we do find to be quite a challenge. With children they can be really distressing, and we are asking the parents to help with wound care quite a lot, so it's important we find something that's easy for them to use. I've included some slides on cold burns just because the pathophysiology is very different to that of thermal burns, of hot burns, but we are seeing more and more of them. It's really important to understand the underlying mechanism because it is slightly different, and you do get this progressive dermal ischemia that occurs. The rate of epithelialization can be a lot slower as well, and they can be a real challenge to heal. We have seen a huge increase in our young adult population recently. This is largely down to an increase in nitrous oxide and the easy availability of it that teenagers and young adults are using for recreational use, and they hold the canister between their thighs and don't realise that it's getting very cold, and it causes quite a significant deep cold burn. This is our most recent data on cold burns, and as you can see we've had a significant increase in these type of injuries over the last couple of years. This is a case study on a small cold burn and how long they can take to heal in comparison to, say, a small deep dermal injury from thermal injuries. They can be a real challenge to heal, and we did heal this one eventually with a combination of honey dressings on occasions and FLAMINAL creams. We fluctuated between using the Forte and the Hydro depending on where the wound was at in terms of moisture and exudate, but as you can see it did take quite a long time to heal, and it did go through very slowly all the stages of wound healing in terms of being deep, in terms of the slough, and then the hypergranulation at around 8 weeks, but it did eventually heal after 12 weeks. Contact burns are very common in children. They do reach up and touch hot things like the hob or the oven door or the iron, and you can see that this initial injury looked to be really quite a nasty injury, quite deep. We did use FLAMINAL on this wound because it's really comfortable and it conforms well to the palm area. We were changing it every 3 to 4 days or so for the first week at least, and you can see that within 2 weeks it actually healed really nicely with really good effect. Hot water bottle scalds are another burn injury that's become increasingly common for us, particularly with the advent of financial challenges and people preferring to use hot water bottles rather than to heat the whole house environment, and they do split and they can cause these really nasty burn injuries. But as you can see, again, this was a patient where we used FLAMINAL to heal their wound, and initially we used FLAMINAL Forte because the wound was quite wet, and then we changed it to FLAMINAL Hydro, and really within 8 days the burn was significantly healed, and by 2 weeks it was completely healed with very good effect. The family were also able to do some of these dressings at home as the burn healed. Foot burns is an area that can be quite challenging. This was a child who had stood on the sand after a disposable barbecue had been recently removed. So the sand had been superheated and was holding the heat. The child ran across with bare feet, and as you can see ended up with quite a significant burn wound. But actually once we debrided all that devitalized tissue, we then used FLAMINAL for 2 weeks, and within 2 weeks this burn was healing really nicely, despite it being quite a deep burn. Again, the advantages of using FLAMINAL here was that it conformed to the shape of the foot. It was also very comfortable for the child, and healed the burn really nicely within 2 to 3 weeks. So in conclusion, wound healing can be a real challenge. It's a complex balance. So many factors can affect how a wound heals, and the management very much depends on the size and the depth and the mechanism of the injury in the first place. Wound healing is absolutely a multidisciplinary approach and a holistic approach, and it's really important that you have the whole team on board, including the family, to get a burn wound healed. And we know that burn wounds can be really traumatic, but I just wanted to share that this is little Sophie, a 4-year-old. She wrote to us after a burn had healed and said, "Thank you for looking after me. I've had a lovely time." And if somebody with a burn injury can be having a lovely time, then we must be getting something right. And here are the references just for your information. Very happy to take questions, and it would be really nice to have a conversation about how our wound care approaches differ so that we can learn from each other. Thank you for listening.